So today we will discuss about cephalometrics and orthodontics. As you all know, cephalometrics is one of the most important diagnostic tool for any kind of orthodontic treatment. So cephalometric means cephalo means head and metric means the measurement. In 1931, Broadband in USA and Hofrath in Germany simultaneously presented a standardized cephalometric technique using a high-powered X-ray machine and a cephalostat. Craniometry involved measurement of craniofacial dimensions of skull of dead person. It can be said to be the forerunner of cephalometry. So most of the landmarks which we today use in cephalometrics are of the landmarks of craniometry itself. So according to Broadman, it is a study, measurement, description, analyzing the changes occurring in craniofacial complex due to growth and development. So these are the two basic cephalograms which we take in orthodontic diagnosis. The first one is lateral cephalogram, which we routinely take in each and every cases to analyze the malocclusion, skeletal and dental problems. The second one is cephalometric frontal cephalogram, which we usually do this cephalograms when the patient comes with any kind of facial asymmetry. So how should be the lateral cephalogram be standardized? Because you cannot take any way you feel like. There has to be a proper standardized protocol to take a lateral cephalogram. So cephalometric radiographs are taken by cephalostat. As you can see in the picture, the patient is standing on a cephalostat that consists of an X-ray source and a head holding device. It consists of two ear rods that prevent the movement of the head in horizontal plane and an orbital pointer for vertical stabilization. So as you can see, there are two ear rods for horizontal stabilization and one just between the eyes, that is the orbital pointer for the vertical stabilization, so that the head is stable and patient does not move in any ways. The upper part of the forehead is supported by forehead clamp above the region of the nasal bridge. The distance should also be standardized between the X-ray source and the mid-sagittal plane of the patient is fixed at 5 feet. Thus, the equipment helps in standardizing the radiograph by use of constant head position, source film distance, so that serial radiograph can be compared. So, in orthodontics, we not only do the treatment, we also do a lot of growth studies. So, unless until your lateral cephalograms are standardized, you cannot compare it, you cannot superimpose it. For the progress of the treatment, sometimes we used to superimpose our lateral cephalograms just to check how the treatment progress is going on, or if you want to compare your pre-treatment and post-treatment result. So, proper standardized radiograph should be taken, then only you will be able to justify your treatment which has been done. Use of cephalometrics. So it helps the orthodontic diagnosis by enabling study of skeletal, dental, soft tissue structure of craniofacial region. Helps in classification of malocclusion, helps in treatment planning, evaluation of treatment results, helps in predicting growth-related changes. It is also valuable aid in research work involving the craniodental region. So there are certain landmarks which has to be taken care of. Cephalometric makes use of certain landmarks or points on the skull which are used for quantitative analysis and measurements. The cephalometric landmarks can be of two types, that is anatomic landmark. These structures represent actual anatomic structures of the skull. Derived landmarks, these landmarks are obtained secondary from the anatomic structures in the cephalograms. So mostly these questions are asked in your viva: what is anatomic landmark and what is derived landmarks? So the landmarks that are used in cephalometrics should fulfill certain requirements. It should be easily seen in the radiograph. It should be uniform in outline and should be reproducible. The landmark should permit valid quantitative measurements of line and angles projected from them. So there are certain landmarks which I have drawn for you to understand. This is the sella. This is maxilla. This is the whole mandible covering the symphysis, the ramus, the condyle, and the body of the mandible. This is pterygomaxillary fissure. This is the orbital plane or the orbital ridge. These are certain points which you have to mark on the lateral cephalogram, through which you can draw lines and angles for the measurement. So this one is the nasion, the most anterior point midway between the frontal and the nasal bone on the frontonasal suture. Orbital, the lowest point on the inferior margin of the orbit. Posterior nasal spine, the intersection of continuation of anterior wall of the pterygopalatine fossa and floor of the nose, marking the distal limit of the maxilla. So this is the end limit of the maxilla. Point A, it is the deepest point in the midline between ANS and alveolar crest between two central incisors. Prostheon, the lowest and most anterior point on the alveolar bone in the middle between the upper and lower central incisors, between the central incisors. Point B, it is the deepest point in the midline between alveolar crest of the mandible and mental process. Pogonion is the anterior-most point on the bony chin. Nathion is the most anterior inferior point on the symphysis of the chin. Menton is the most inferior midline point on the mandibular symphysis. Gonion, it is at the junction of the ramal plane and the mandibular plane. Articular is at the point of junction of posterior bot of the ramus and the inferior bot of the basilar part of the occipital bone. Orion, the highest bony point on the upper margin of the external auditory meatus. Sella point, the point represents the midpoint of the pituitary fossa. Sella entrance. Now there are various planes in the cephalometrics. These comes in your short notes also, describe some planes in cephalometrics. There are few horizontal plane, that is SN plane, that is the plane between S and N point. It is the line between sella and nasion, represent anterior cranial base. FH plane, plane between orbital and orion. Palatal plane, plane between ANS and PNS. Occlusal plane, plane bisecting the posterior occlusal of permanent molars and premolars. Mandibular plane, tangent to the lower border of the mandible if you are doing Tweed's analysis. A line connecting to gonion to nathion in Steiner analysis. A line connecting gonion to menton in Downs analysis. Basion-nasion plane. This is basion-nasion plane. Line connecting the basion and the nasion representing a cranial base. Basion is the point on the anterior margin of the foramen magnum. Bolton's plane, plane that connects Bolton points posterior to occipital condyle and nasion. Bolton is the highest point on the posterior condylar notch of occipital bone. Then there are few vertical planes. APOG line, line from point A to Pogonion, point A to Pogonion. Facial axis, a line from PTM to cephalometric nathion. E plane, also called aesthetic plane, is the line between most anterior point of the soft tissue, nose and chin. So we'll go for the first basic analysis, that is a Downs analysis. The first is the facial angle. The facial angle is drawn between sella and Pogonion and FH plane. It marks the internal reading. So the mean reading is 87.5 degrees and the range is 82 to 95 degrees. So it tells about whether your mandible is prognathic. If it increases, it tells the mandible is prognathic. If it decreases, it tells that the mandible is retrognathic. Next is the AB plane. It is the APOG line and the line between point A and point B. This angle marks the relationship between the maxilla and the mandible to each other. The mean reading is minus 4.6 degrees and the range is 0 to 9 degrees. It tells about whether the maxilla is prognathic or retrognathic, or mandible is prognathic or retrognathic. Next is the mandibular plane. It is between gonion and menton, and the FH plane. This reading, it tells about the growth pattern of the mandible, whether it is a vertical growth or a horizontal growth. The mean reading is 21.9 degrees and the range is between 17 to 28 degrees. Then y-axis, it also tells about the growth pattern of the mandible. So it is between the FH plane and the sella and cephalometeics. So this angle, it tells about, this is known as y-axis. The reading is 59.4 degrees and the range is 53 to 66 degrees. Then cant of occlusal plane, this tells about whether the occlusal plane is steep or it is normal or it is growing in anterior and forward direction. So it is between the functional occlusal plane and the FH line. The mean reading is 9.3 degrees and the range is 1.5 degree to 1.4 degrees. Interincisal angle, it tells about the relationship of uh, upper and lower anteriors to each other, whether they are anteriors are proclined or retroclined. So a long axis is drawn of upper and lower anterior, and the internal angle is recorded. So the mean reading is 135 degrees, and the range is 130 to 140 degree. The lesser degree will it will be increased in more proclined teeth. If the teeth are more upright, the degree will be more. Incisor mandibular plane angle, that is whether the lower incisors are proclined or retroclined in relationship to mandibular plane. So the mean reading is 1.4 degrees and the range is minus 8.5 to 7 degrees. So long axis is drawn and gonion and menton plane. This internal angle is marked and the reading is analyzed. Next is the Steiner analysis. Steiners have also divided his analysis between the skeletal dental problems. So, like Downs analysis, we use FH plane in Steiner analysis. We take SN plane for all the analysis. So the first reading is SNA angle. As the name suggests, it is between the SN plane and the point A. This internal reading is should be recorded, and the mean reading is 82 degrees. If it is a prognathic maxilla, the angular measurement will increase. If it is a retrognathic, the under measurement will reduce. Similarly, for SNB, it is between the SN plane and the point B. The internal reading is marked. The mean reading is 80 degree. If the mandible is prognathic, the reading will increase. If the mandibular is retrognathic, the reading will decrease. A and B angle, this angle suggests the interrelationship of maxilla and mandible to each other. It is the angle formed between end point and A and end point to point B. This internal reading is marked. The normal reading is 2 degrees. If it is increased, that means the mandible is retrognathic. If it is decreased, that is the mandible is prognathic. Similarly for the maxilla also. Occlusal plane, SN2 occlusal plane is marked and the angular measurement is measured. The normal should be 14 degrees. If it is increased, that means the mandible is rotated downward and backward and your occlusal plane is steep. If it is decreased, that means the mandible is rotated upward and forward and you get a less steeper occlusal plane. Mandibular plane, how is the growth of the mandible? So the line is drawn from gonion to gnathion and it is the angular measurement is taken from the SN plane. The mean reading is 32 degree. If it increases, that means the mandible is rotated downward and backward. So the patient is a vertical grower. If it is decreased, the patient is horizontal grower and the mandible is rotated in upward and forward direction. So this is the maxillary and mandibular incisor relationship to each other. SNA line is drawn and the long axis of the tooth is drawn and we measure the internal angle. The internal angle normal is 22 degrees. It increases if the tooth is proclined, it decreases if the tooth is retroclined. Similarly, the label surface, the linear measurement could be done from the label surface of the tooth surface. It should be 4 millimeter. Procline, it will increase. Retrocline, it will decrease. Similarly, is for the mandibular teeth also. SNB line is drawn and the long axis of the tooth is drawn and this angular measurement is done. 25 degrees is normal. If it is increased, the tooth is proclined. If it is decreased, the tooth is retroclined. And we also compare the lower incisor to the chin relationship for the aesthetic purpose. It should be 1:1. If there is 4 millimeter of lower incisors proclination is there, so the chin distance from the chin to this B line should be also 4 millimeter. The ratio should be 1:1 millimeter in proper aesthetic patients. If it is increased or decreased, so we can predict the position of the chin in relationship to lower incisor. And accordingly, we can plan our treatment. Interincisal, it is almost same like the Downs analysis. Long axis is drawn and the internal angle is measured. The normal is 130 degrees. In procline teeth, the angle will increase. In procline, it will increase. In retrocline, it will decrease. Sorry, in retrocline, it will increase. In procline, it will decrease. Lower incisor to chin position, like I've already told you, long axis is drawn and the linear measurement is done from the NB line. So it is the relationship of the chin to lower incisor. It should be 1:1 in proper aesthetic balance. Next is the width appraisal. It tells about the relationship of maxilla and mandible to each other, whether the maxilla is prognathic or mandible is prognathic, or maxilla is retrographic or mandible is retrographic. So occlusal plane is drawn and a perpendicular line is drawn from point A to occlusal plane, and perpendicular line is drawn from point B to occlusal plane. So this distance is measured. In males, the BO is ahead of AO by 1 millimeter. In females, AO and BO coincides. So accordingly, you can plan whether the mandible is prognathic or retrographic or maxilla is prognathic or retrographic. The last one is the Tweeds analysis. So basically, it takes the FH plane, the long axis of the tooth, and the mandibular plane, which he draws from the tangent to the lower border of the mandible. So this internal angle tells the IMPA. This internal angle tells the FMIA, Frankfurt mandibular incisal angle, and FMA is Frankfurt mandibular angle. So this angle tells the mandibular plane. This angle tells the inclination of the lower incisors. This angle tells the inclination of the lower incisor and prognosis of the treatment. So in normal situations, the IMPA should be 90 degree, FMPA should be 25 degrees, and FMIA should be 65 degrees. Next is the soft tissue analysis. There are certain landmarks. First is the S line. It is drawn from the curvature of the nose to the tip of the chin, and you see the distance of the upper lip and the lower lip. Similarly, the E line, that is the aesthetic line, it is drawn from the tip of the nose to the tip of the chin, and you see the position of the upper and lower lip. H line is also drawn from the tip of the nose, which touches the lower lip. Nasolabial angle, it is the angle drawn from the lower border of the nose to the most prominent part of the upper lip. This angle is measured. Nasomental angle, the bridge of the nose is marked and the E line is marked, and we measure the internal angle. This tells about the overall aesthetic relationship or the of the face of that particular individual. Soft tissue chin thickness, how is the soft tissue of the patient? So it measured from the hard tissue pogonion to the soft tissue pogonion. Upper lip prominence is measured. A perpendicular line is dropped from from the deepest point of the lip, and the upper part of the lip is measured. Similarly, the lower lip is measured. The vertical line is drawn, passing to the deepest point of the nose, and the prominence of the upper lip is measured. And with the same line, we measure the prominence of the chin. So in normal situation, the S line should be touching both upper and lower lip, and the E line, upper lip should be 4 millimeter behind and lower lip should be 2 millimeter behind. In H line, the lower lip should be behind. In nasolabial angle, 102 plus minus 4 degrees considered as normal. Nasomental angle 120 to 132 degrees is considered normal. Soft tissue chin thickness should be 10 to 12 millimeters. Upper lip prominence should be 1 millimeter to 2 millimeter ahead. Lower lip prominence should be 1 millimeter behind, and the chin prominence should be 1 millimeter behind in normal cases or aesthetic pleasing cases. So this was all about